Hello, I'm Magnus Ohman here at CRT2014 Live. I'm here with Dr. Eric Bates from University of Michigan, a true all-blue gentleman, and he has been very much involved with door-to-balloon time. And so the question for you, Eric, what is this really, we really need to follow this as closely as we have, benchmark every hospital in the country. Is it really going to be that useful?
Well, I think it's been tremendously useful in decreasing the logistical delays that were in everybody's system several years ago. But I think a strong argument can be made that we've obtained most of the benefit in taking out those delays, and that now everybody is getting very good door-to-balloon times in over 90% of their patients.
And so we went from 2 to 3 hours down to 90, maybe towards 60. And I think that's been a terrific change. Do you see us getting much better, or do you think we're saturated to what we can do, given that we have a patient at the other end who has to make some decision about his own health care?
Yeah, I think maybe the enthusiasm for hitting this metric and reporting it has become too strong. There are some unintended consequences by trying to take 5 more minutes off that reportable measure every year. And those include the false activation rate, which is 30 or 40% at my hospital, and probably the same at yours.
25% in North Carolina.
Yeah. The limitations of doing a full patient assessment to make sure that the patient doesn't have another condition that might be masquerading as an MI, or that you get informed consent. The gaming of the system, where you go right to the intervention and perhaps don't do the procedure in the normal standards so that you can get a shorter time. So I think we have to remember that this is a quality metric. It was made to improve timely treatment, but I think we've maxed out on it, and we really ought to be turning our attention to the pre-hospital systems of delay, where we still have some major opportunities for decreasing total ischemic time.
So based on your experience from University of Michigan, and you've obviously also been involved on the national level on this, what are the types of patients where we should consider putting up a not a stop sign, but a sort of think twice sign in your practice? Is there any particular patient?
About going to primary PCI?
Yeah.
Well, I don't think door-to-balloon time should be in that equation. There's increasing pressure and evidence supporting the concept of taking all cardiac arrest patients that are resuscitated to the cath lab. There's been pressure to take the cardiogenic shock patients to the cath lab. It appears that the highest risk patients are where you get your biggest mortality advantage from PCI, but conversely, if you're dealing with door-to-balloon time reporting or mortality reporting with public reporting, there's a negative incentive to take those patients to the lab. So I think clinical judgment is still most important. I try not to worry about my door-to-balloon time or my mortality rate. There are clearly some unsalvageable patients where care would be futile, and I don't think they should go to the cath lab. But this cardiac arrest story is quite interesting. I would not take patients to the lab before unless they woke up, and now we're increasingly taking these patients that are still unconscious to the cath lab, and some of these patients are surviving, which is quite impressive with a therapeutic hypothermia.
Which is obviously terrific. Now, in a public reporting setting, though, those gets counted against you.
Yeah.
And they're by definition dead on arrival. So how do you think we should handle this?
No, that's not quite right. It turns out in the door-to-balloon reporting metrics that the hospitals put in, which are 1-year summary statements, you can take patients out of the denominator. So anybody that goes on a ventilator gets pulled out. Anybody with prolonged access issues gets pulled out. So I think we're doing great, and I assume most hospitals are 90-95%, but we don't see the patients that are excluded from that reporting metric. So there actually is no disincentive in the door-to-balloon time number for taking on cardiogenic shock or resuscitated cardiac arrest, because they don't count on the reporting measure.
But as you mentioned earlier, if you do PCI on that patient and you're in a state that publicly reports,
counts on your mortality reporting, not
now
your
you're going to
door-to-balloon
look
time.
kind of awkward.
So we've seen that. We saw that experiment done in 3 states with public reporting, and it's been reported that they actually are more selective, and that PCI in the high-risk patients is being withheld from some of these patients, probably because of the concern about public reporting. So that's a moral issue we have to address and a clinical issue we have to be aware of.
What about the elderly and unknown code status? So the 85 years
Right.
plus. How do we deal with this? This is tricky, isn't it?
On an individual basis. I would be very cautious on taking patients from nursing homes or assisted living situations to the cath lab as quickly as people are independent. But the older I get, the less worried I am about treating elderly patients. And there certainly are a number of octogenarians who do very well and come through the cath lab. And with the modern PCI procedure with stent implantation and quick procedures and the better contrast media, the complications we used to have 20, 30 years ago really aren't quite as important. So I think you have to be concerned about bleeding. You have to be concerned about the quality of life when they survive. But we're treating 80-year-olds more like 60-year-olds every year.
Well, that's have been a national trend. Now, you spoke earlier a little bit about potentially working upstream, how we can get things better. Give us some ideas what that might involve.
Well, Mission Lifeline, a program sponsored by the American Heart Association, has been trying to encourage communities to have established pre-hospital systems of care depending on their resources and their geography. So some institutions may have hospital transfer arrangements in place. Others may have EMS systems with permission to bypass hospitals that don't have PCI capability and take patients directly to the PCI capable hospital, even though it's a longer transport distance. So I think the concept is to do what we did on the in-hospital system of care, figure out what's possible and what you need to do to decrease that time from symptom onset to arrival in the hospital with PCI care, because there's still some major logistical delays because you can't find an ambulance, or the patient on duty hasn't dealt with somebody and they can't find the protocol. So the same issues we went through 10 years ago with Doortoballoon time, I think we can apply that strategy to decreasing pre-hospital delays. So
you see that very much like a hub and spoke system where every hospital in a state or in a region are coordinated and practicing?
It would be great to have regional coordination or statewide coordination like you do in North Carolina. But I think at a practical level, with all kinds of different hospital systems across the country, the important thing is that every hospital should have a developed protocol in place for how they're going to handle their STEMI patients, both in the pre-hospital system and in the transfer to a hospital with PCI capability.
Do you think we will get to the European system that some countries have with mobile ambulances with physicians in place?
No. I think a lot of those countries are really very small regions, and they don't have the same logistical geographic transportation issues that we have, and there's a different healthcare system. So in the U.S., I think a national policy would be great, but I think practically the most important thing is a regional or even a local policy where you do the best job you can with the resources you have.
Thank you, Eric. Great words of wisdom from somebody who's been in the trenches for this for a long time. And thank you to your audience for participating with Live CRT 2014.